Thanks, everybody. It's a real pleasure to be here. So, let's see if I can get my clicker here. Aha. So, I was asked here to talk about a specific subgroup of newcomers, although I think we can recognize that there's a spectrum of migration that happens, and refugees are one point on that spectrum, but I know that it's something that's on everybody's minds presently. It's certainly on my mind all the time right now. And so I'm just going to talk about some of the specific things that we encounter at our clinic, which is a specialized clinic for refugees at any point in their process to arrive in the Lower Mainland. So I'm just going to give a little bit of background on the topic of refugees generally, although I imagine that most of the people who are the audience here have a pretty good idea, but I'll just review and then talk a little bit about what we do at Bridge Clinic, and then spend a longer time talking about some of what we do in terms of helping people navigate the mainstream healthcare system, and talk more about some of the barriers that we see people encounter, and then we'll reserve all the discussion for the end. So just to review, there is an actual definition of a refugee, which not everybody is aware of, but basically it's a person who, owing to a well-founded fear of being persecuted, for reasons, and these are reasons we consider intrinsic to a person, reasons of race, religion, nationality, membership of a particular social group that might be LGBTQ, or a political opinion, is outside of the country of their nationality, and is unable to or unwilling, owing to such fear, cannot avail themselves of the protection of that country. So they have to be outside of their country and unable or unwilling to go back. Here in Canada, there's sort of two main pathways that refugees arrive. The first is that they can be sponsored. So they can be sponsored by the government, they can be sponsored by a private sponsor, which in many cases is can be a faith-based or community group, or there is a blended sponsorship option where there's sort of a combination of government and private resources sponsoring a person or a family. So the way the pathway goes is that a person might flee their homeland, and right now the UNHCR estimates there's about 14 million sort of refugees of concern in the world. They go to another country to make a refugee claim. The pathway we're familiar with is through the UNHCR, but there's other ways as well. And then about 1% of those get chosen for resettlement. There are other what we call durable solutions for refugees. Some of those include being repatriated voluntarily, or sort of making a permanent home in the country in which they claimed asylum. Resettlement involves actually being taken to a third-party country, not the country where you claimed asylum, but to another country, in this case Canada, but the primary resettlement countries are United States, Australia, and the Scandinavian countries, although there are more than that. And only about 1% actually get taken from the country of asylum and taken for permanent resettlement. It's assumed to be permanent in another third-party country. And there they should have access to all the rights of a permanent resident or a citizen of that country. The second pathway is what we would sort of consider asylum seekers. Here they're called refugee claimants, in which case they flee their homeland, they make their way through any way possible to our border, make a claim of asylum here, and then their case is adjudicated here in Canada. If their claim is accepted, then they immediately become a permanent resident of Canada. If their claim is rejected, they have a few different options. Many people appeal. Some people will make a humanitarian and compassionate application. Some cases they're deported, and many times people continue to live here undocumented, which is why I consider this a spectrum, because some people are coming through situations that may not fit the exact criteria of a refugee, but doesn't mean they don't have needs, and they're still living here. So this is something that we'll probably end up talking a little bit about at the end. These are the numbers from 2014, because they haven't published the 2015 numbers yet. But refugees as a whole Canada takes in about 25,000 a year. Typically, BC gets about 10% of those. So you can see the numbers here for the different categories. GAR is government-sponsored, PSR is private-sponsored, RC is refugee claimant. Dependents are people who are brought in usually in what's called the one-year window, where people, their families may have been separated in the migration process, and they're allowed to apply for family members to come as dependents in sort of the first year after arrival. And then refugees in British Columbia. So here I'm actually specifically talking about government-assisted refugees. The numbers are a little bit harder to ascertain for refugee claimants, and at present the number of refugee claimants is a bit smaller than the government-sponsored, because we are undergoing a huge push by the federal government to bring over a lot of government-sponsored refugees. So I'm just going to talk about them for the moment. So the top 5 source countries in 2015, and this is to British Columbia, were Syria, Iraq, Iran, Eritrea, and the Somali Republic. So as you can see, the numbers are going up and up. So in 2014, the target was 800, but we actually got 941 GARs. In 2015, we got over 1,000, and in 2016, to be determined, but the target's probably close to 4,000. There's not yet a complete body of research looking at all the streams of newcomers, and that's, a lot of work that has yet to be done, and hopefully will be done now that there is more and more of a focus on newcomers. But what we know is that of refugees who land in Canada, they have an increased burden of chronic disease and increased prevalence of infectious diseases. So things that we see commonly: anemia, neglected chronic diseases like hypertension, diabetes. We see cervical pathology, because many people are coming from health systems where they may not have been screened for HPV. And then increased prevalence of infectious diseases, as you might imagine. Hepatitis B, HIV, intestinal parasites, and being susceptible to varicella. One of the things I think it's important to point out about this is that most of this disease burden are preventable or treatable, which means that there's a really significant role to play of primary care, which often gets neglected. Sometimes people are very concerned about the acute facets of this disease, but there's a real role for primary healthcare providers here in terms of helping newcomers manage their health issues and integrate and be able to focus on settlement. We're the Bridge Clinic. So we are a clinic specializing in refugee healthcare. We're in the Vancouver Coastal Health Authority. About 2/3 of all the refugees that come to BC are seen for screening and primary care at our clinic, and it's been operating in some form for over 20 years. Here are some of the services that we provide. Oh, somehow that circle got in there, but it's not supposed to look quite like that, but you can get a sense for what it should look like. So when refugees arrive, they can either be referred to us by a settlement agency, like a refugee claimant might make their way to us referred by a settlement worker or somebody else. We have a relationship with ISS of BC, where all of the government-assisted refugees who arrive through ISS of BC are seen by our outreach team for initial screening. So we do a little presentation talking about the healthcare system, what rights are, what are commonly encountered questions, who is your family doctor, what is the family doctor's role, how do you fill a prescription, sort of things like that. We do some initial screening blood tests, we do some initial vaccination assessment, we provide specialist referrals, we provide general primary care, testing for specific infectious diseases, and we always provide, when possible, live one-on-one interpretation, or we use the PLS phone service. I should note that our services are considered transitional. So Our goal is to receive people, help them integrate, understand, adjust to the system, and then we try to help them transition into the community care. So that might be a regular fee-for-service family physician, it might be another specialized clinic, usually in the Fraser region because most of our clients end up ultimately settling in the Fraser region. So they have some specialized refugee health clinics there for people who might not have an easy time integrating sort of earlier on into the regular mainstream healthcare system, but we do at some level try to facilitate a transition into the community, and I think that's where this conversation can be really productive, because I find that's something that we're all struggling with, is how do we help people, how do we provide all these services initially, but then help kind of expand it into the larger system. So I'm going to step back a little bit here just so that I can kind of frame the process. Until this year, all government-assisted refugees to British Columbia would arrive, come over on the plane to YVR, they'd come to the Welcome House, and they stay in the Welcome House for a couple of weeks until they can be permanently housed. During that time, we send an outreach team out there to do the initial screening, blood work, and vaccinations. And then we bring people in for follow-up at the Bridge Clinic. Over time, we transfer them either to the New Canadians clinics or into the community care that I was describing. And during that time, they might interact with the healthcare system in a number of ways. Hospitals, emergency departments, public health clinics, walk-in clinics, and specialists. Starting this year, for the first time in a really long time, GARs are coming, and they're not going through the Welcome House. They're actually going all over the province now. As of, and I mean, you guys might even be more up to date than me, but as of last week, government-assisted refugees are arriving in Vancouver, Abbotsford, Nanaimo, Kelowna, Prince George, Kamloops, and I think there might be a couple more sites forthcoming. So this is a really important discussion for us to be having now, because for the longest time, a lot of this knowledge was centralized at Bridge Clinic, but it's going to have to expand province-wide pretty quickly. What we're finding is that now that people are being spread all over the place, they're interacting with the healthcare system at a number of levels, kind of without the initial introduction piece that we've been providing traditionally. So people are just going to the emergency, you know, showing up at walk-in clinics. They might first interact with allied health, PT, OT. They might first interact with a dentist or at a pharmacy. A lot of times people are identified at schools and then they're referred to us. So the process and the order is getting a little bit scrambled now. Through this process, some of the barriers that we have identified, and this is going to be super familiar to all of you here, but I think it's nice to kind of bring it all together in one place. Barriers can appear at a number of different levels. So at the individual level, language is obviously a huge barrier and one that we're going to spend more time talking about. Culture, so paradigms of care, how you view alternative care, how you view preventative care, those things might be vastly different than you know, our paradigm here in Canada. You know, shame, distrust, fear, guilt, denial, all of those things can exist for people who are coming from places where they were living in a system that was oppressive. So many people come and they have a built-in distrust of the government or a larger system, whereas here we tend to be sort of trusting of those of those systems. In other places, if you've been oppressed, you know, in the healthcare system or by the government, it's not as easy as just landing in this country to reverse that feeling. There are significant financial barriers that you all probably encounter, and just lack of knowledge about the system. So that's why I thought the work Anne was describing is really important, just sort of that initial intermediary piece of how is this system organized? I mean, honestly, many Canadians may not fully understand that. You know, I think it's important for all of us to know sort of how the pieces fit together. You know, I often tell people, you know, or learners that come to me, like, imagine that you were traveling and you suddenly had a health emergency, you had to go someplace, and you might question what some of the people are doing in terms of how they're managing your care. Certainly the same thing happens here, and it's completely understandable. At the provider level, you know, as a provider, I can say there's a lot of barriers that sort of are generated by us. Part of that also is culture and beliefs about how healthcare works, how health is practiced. A lack of awareness of migration at all, newcomer health, refugee statuses, just being overwhelmed. Everybody's busy, everybody's working hard, and asking people to take a few extra steps can just be a bridge too far. Lack of financial reimbursement, so that sometimes is more of a perception than a reality, but people may believe that they have to provide services either for free or they're asked to provide services for free that might be reimbursed, but they may not be aware of how to get the reimbursement. And a lack of support services. And this is where I think, doing this like environmental scan of all the things that are available and pointing out that it's disconnected from the people providing healthcare on the ground, that's so pertinent and something we should be working on, is that there actually are quite a few services that exist, especially around settlement and support, but they're just not linked in with healthcare super well. And then finally, there can be systematic barriers. The interim federal health care program, which I'll talk a little bit more about later, and delays in getting MSP for people can provide significant barriers to care. So I'll talk a little bit about language barriers because this is something we're all familiar with. So what we use at Bridge, and is used widely, I think, the Provincial Language Service, which is an in-person or a phone medical interpretation service. Many of the health authorities pay for this service for their own hospitals and clinics. It is available to fee-for-service GPs for a fee. So that's why I put it's not yet available, because in practice, pretty much no one is willing to pay out of their own pocket for the services. The services are technically available in that, you could pay $1.80 a minute to use the phone interpreter and have your patient, but at that point, you've essentially paid more for the visit than you've gotten by billing for the visit, which is such an insurmountable barrier for fee-for-service physicians on the ground. So in practice, they just don't really use the service. But what we're learning is that if you provide the service funded, people will use it, and they tend to like it. And so that's why I noted that it's underutilized even when it's available. There have been a few very small experiments through the divisions of family practice where they have funded interpretation services for just on-the-ground family physicians, and the people who have used it have really liked it, but not very many people have been using it. So there's some work to be done there in terms of spreading that message. But other ways that people overcome language barriers are just using ad hoc interpreters. So we've seen people use family members, friends, Google Translate in a pinch. This isn't always perfect or appropriate, but can be sometimes used. Settlement agencies sometimes provide paid interpreters, and they're used broadly in other situations outside of the healthcare sector, but sometimes they are used in healthcare, and I'm speaking for different health authorities where this may be their main way of accessing interpretation. And then community volunteers sometimes provide interpretation. So you have local cultural or religious groups that will sometimes provide interpretation for their clients, but again, that's not always considered appropriate because there may be certain issues about your own health that you may not feel comfortable disclosing to a member of your own sort of religious or community group. In terms of barrier providers, we've done some talking already about the idea of cultural navigators or brokers, and I really think that's a direction that we should be pursuing very, very hard in the future, because I think that's going to help us kind of overcome not only some of the language barriers, but just understanding and adapting into this system. It would be great, and something I'm working on personally is to develop an online forum of clinicians to share practices and resources sort of province-wide, especially now that refugees are going all over, doing continuing professional development. So working with the UBC CPD to come up with workshops and webinars aimed at fee-for-service family physicians to help encourage them to take newcomers or refugees into their practices, collaborating with divisions of family practice and other professional organizations. So working on attachment, language, raising awareness and advocacy among providers to help sort of break down those barriers and encourage them to bring people into their practices and see it as just part of the spectrum of, family medicine. And then integration into healthcare or health training curriculum. So, getting into the training programs, both in medicine, nursing, social work, to sort of, again, broaden awareness of migrant health and newcomer health more generally. And then finally, overcoming systemic barriers. This is the biggest challenge, and the one where we need to collaborate the most. So the Interim Federal Health Program, I will just note, is an insurance program funded by the federal government that covers refugees at different levels depending on the stream of refugees. But as of April 1st, the same coverage will apply to all refugees regardless of which stream they came into. There used to be this horrific chart I used to have to show every time I did this presentation that was a breakdown of the different types of coverage at every different level of refugee, and it is I barely understand it, and this is the work I do, and everybody would just look at that chart and sort of run away screaming. And what we did find was that on the ground, even when people had insurance, when providers found out that there was a refugee patient, they would simply deny a service because they couldn't manage to navigate through the complex web of coverage. So part of the liberal government platform around immigration has been to reverse these changes and make it so that all refugees arriving after April 1st have the same coverage. That coverage includes physician diagnostic and lab testing services, so basically what would normally be covered by MSP. It provides medication coverage more or less commensurate with what people get if they're on income assistance for medication coverage. And then limited vision, dental, and supplemental services. Supplemental services might be physiotherapy, braces, wheelchairs, those kinds of things. And I can't emphasize this enough, doesn't matter what type of refugee you are after April 1st, you will have access to this coverage. The medical services plan, which is the provincial insurance that covers all permanent residents in Canada, is available to government and private sponsored refugees when they arrive, the day that they land. As soon as they're permanent residents, they can apply for MSP. When a refugee claimant is accepted after their claim is adjudicated and they're given their permanent resident status, they can also apply. And they are not subject to the 3-month wait period that most people are. So when I moved to BC from Ontario, I had to wait for 3 months. I could apply, but I had to wait for 3 months to apply for MSP. But in this case, that 3-month wait period is waived. You can apply for MSP just as soon as you have your permanent resident status. This is really important for all the settlement agencies to understand across the province, is that as soon as you come into contact with a newcomer who is coming as a refugee, check and make sure that they have applied, because even though they're eligible, they won't be given MSP until they've made the application. Now, the barrier for us here is that there can be an administrative delay. So although you're eligible for MSP, even if you applied on the first day that you landed, your application basically goes into a queue for activation. And that activation period can be anywhere from 2 to 12 weeks, we've found. We haven't found there's a lot of patterns to it. Sometimes it can take longer than others. It's not always clear why. And that can be a real barrier for people, even though they're already covered by IFH, because as I've described, many providers don't want to take a third-party insurance, and they want to wait for people to have their MSP activated. One thing that we've talked about with the MSP services director at the provincial level is that we'll try to prioritize activating these applications as quickly as possible, but one thing they did say is that, and this you can tell, and this is a point of advocacy for anyone working with refugees, is that when you go to any healthcare provider, you can tell them that this person is eligible for MSP, and maybe they've applied. If they've been given an MSP number that isn't activated, the provider can hang on to that number and back bill it for up to 90 days. So if the MSP number that the person has isn't active, just tell the provider, just hang on to the number. Try it again in 2 weeks, try it again in 3 weeks. Just keep trying, and then it will go through, and you can just back bill all the services. So there's really almost no need to ever upfront charge a refugee client for care. just so you know, that we find that at the frontline level, when refugees are trying to access care in the emergency room, often they'll get charged up front, even though that contravenes the Canada Health Act, that confusion about coverage can persist, and it's important for people who are advocates to be able to make it clear to frontline staff that this coverage applies, these are all the routes to getting reimbursed. Finally, at a health authority level, I think it's important that health authorities recognize newcomers as a vulnerable population who will ultimately contribute so much to our society, but that initially might need a little bit extra. A huge and firm commitment to language services at all health authorities would be really important. Communicating that with frontline staff or gatekeepers is essential, because you can have all the great policy you want at an upper level, but if the frontline staff isn't aware of that policy, they may be enforcing a policy that really exists mostly in their head, but that really affects people's care on the ground. And then just engagement with the refugee community. I think too often these discussions happen without the engagement of people themselves who are navigating the system, and we're missing, some crucial pieces there. So finally, just an acknowledgement that as much as we're talking about health right now, most of what affects our health is factors outside of the healthcare system altogether. I know I've just spent a long time talking about all the factors within a healthcare system that affect their health, but I will say that probably settlement affects a person's health so much more than all those other pieces put together. And it's really important to keep those things in mind. So issues of poverty, issues of gender and sexuality, access to schools, access to language classes, family structures, housing, all of those things make such a big, big difference to health. And it's important when we're developing policy to keep those things in mind and to coordinate across sectors, right, to sort of optimize all of the newcomer health. So I know that we're going to be having a discussion later, and just a few of the questions that I'd like to add to the question list to discuss are just how can we improve communication and coordination between healthcare providers and community agencies? Forums like this are a good start. How do we manage competing priorities for limited resources? One of the things I find as I'm asking for resources is that everybody's asking for resources, right? And so how do we manage to do the best that we can with what we have? And then how do we collaborate with refugee clients to understand, navigate, and advocate for themselves within the mainstream healthcare system? I think this is a really important piece, is how do we help people develop a sense of their own rights over time? Because that may not be something that they come with intrinsically. And that's all. Thanks.